Dr. Shepich is going to be talking to us about the management of the incompetent axial great saphenous and small saphenous and perforator veins. I'd like you to all welcome Dr. Shepich, please.
Well, good afternoon, early evening. Thank you for coming today. I kind of wanted to quickly go through some of the varicose vein treatments, is basically what we're going to be talking about today. I'm not going to talk about deep venous insufficiency, more just about varicose veins. As far as the incidence, it's assumed that probably half of adult men and 2/3 of adult women have symptoms of varicose veins. And of those, up to half will have visible varicose veins, symptoms being heaviness in the legs and achiness in the legs. When we talk about varicose veins, the severity can range all the way from cramps, leg cramps at night, swollen ankles, spider veins, all the way through severe edema, ulceration, skin breakdown of the legs. When we talk about the venous disorders, they're divided into acute thromboembolic events and chronic stasis issues. And the stasis issues are both deep and superficial. And as I said, I'm not going to talk about the deep tonight, because most of the treatment of that is not very successful other than symptomatically. About 10% of patients, this 50% of the population has some venous symptoms. 10% will have venous ulcerations. 10% of venous ulcerations in symptomatic patients are due solely to superficial disease. Most ulcerations actually have a component of deep disease associated. 3% of the population with varicose veins will have some sort of skin change. And we can actually help those patients by treating the superficial component of the disease in up to 70% of patients. This is a quick review of the venous anatomy of the legs. The light blue veins are the superficial, the deep system. The superficial system are the deep dark blue veins. The greater saphenous vein and the lesser saphenous vein, or the great saphenous and small saphenous vein, are the two that we most concern ourselves with when we're treating varicose vein issues. The mechanism of varicose veins, the veins in the legs are a valve system. There's a series of one-way valves that allow venous return to the heart. Over time in the superficial system, because the veins aren't well supported from upright posture, from obesity, I actually have a slide coming up with the risk factors. The valves can become incompetent with time. The veins dilate, and this creates a lengthening and a tortuosity of the veins, and kind of a domino effect as the valves continue to fail. The increased venous hypertension at the ankle will lead to fluid accumulation and protein extravasation into the tissues of the leg, and that causes a lot of the stasis changes, the pigmentation, the skin breakdown, the itching, and the dermatitis of the ankles. I'm going to skip to the next slide here. The function of the skeletal muscle pump is kind of underrated when we talk about varicose veins. That superficial system of veins really does not return much blood to the heart in the upright posture. Most of the blood is returned to the deep system, with that superficial system acting as a reservoir function. As the blood is accumulated in the superficial system, when the muscles relax, the blood is drawn into the deep system. And when the muscles contract, there's a series of one-way valves that communicate the superficial to the deep system, keeping the blood from refluxing back out into that deep system. Over time, with pressure, those valves can become incompetent as well, creating focal changes. And I'll show you some pictures of telangiectasias in a second associated with that. This is risk factors. There's actually a story about the graft, the venous return for the graft assisting circulation of blood to its brain, because its heart is thought to be large enough to deliver blood to its brain. But as I was looking into that deeper, I think in the last 2 years they've disproved the siphon effect of the giraffe's brain. But the risk factors: female sex, increased age, obesity, pregnancy, geography, and race all play a role in the formation of varicose veins and venous issues. The symptoms: lots and lots of people have symptoms of varicose veins, as evidenced by all of the over-the-counter medications, treatments, and modalities that kind of shown here. Achiness and heaviness is the most common symptom. Stinging, burning, edema. People can get warm, feel if their legs are hot or burning by the end of the day. Associated with muscle spasms. It can go on to cause clots in the veins, phlebitis, bleeding, and skin changes associated with ulceration or stasis dermatitis. We'll see some pictures of those in a second. In the clinical realm, we use the SEEP classification to talk amongst ourselves as to kind of grade the severity of the veins, to communicate with the insurance companies on the severity for what treatment and payment. And that breaks down to a clinical, etiologic, anatomic, and pathophysiology, which contribute to those veins. These are some pictures of the classifications, all the way from spider veins and spider telangiectasias through the ropey varicosities in the SEEP class 2, edema in the SEEP class 3, pigmentation and eczema of the ankles in the SEEP class 4, healed ulcer in the 5, and an active venous ulcer in the SEEP classification in class 6. And this kind of looks at the incidence of symptoms by SEEP score. I found this slide, I pulled this down off of a medicographia website. It was kind of interesting because this C0 is people that have no visible varicosities, no demonstrable reflux in their veins, and that group of people, very similar symptoms to people with varicose veins. So the thought was that a lot of us would have C0 disease, just a lot of venous symptoms. So we'll see patients in the office that for leg pain and classic varicose vein symptoms, and you really don't have any physiologic reason, and most people will respond to compression stockings and some therapy. So these are the reasons patients come and see us for varicose veins, and the different next few slides are different varicose features that we see. We see the spider veins and the spider telangiectasias. That first picture shows the reticular feeder veins under the skin going to the spider veins more superficially. And then we'll get some of the smaller subcutaneous reticular veins all the way up to the large ropey varicosities. This is a common finding, this corona phlebicatica or phlebicatic corona. It's a kind of a sunburst around the ankle. That can be associated with a lot of the symptoms of heaviness and achiness, and people get burning and stinging leaves. These are the chronic hemosiderin deposition. As those veins become more dilated, there's a transudation of red blood cells into the soft tissue, and the hemosiderin is left behind, and that can lead to ulceration of the ankle. Lipodermatosclerosis, the subcutaneous fat dies from the chronic trauma, extravasation of proteinaceous fluid in the tissues. This is the atrophy blanche. So you see, if you look closely at the ankle area, you can see scarring and reticular formation of scar in the tissues from repeat bouts of inflammation and sometimes small ulcerations. And then frank venous ulceration. The most common reason patients come to us is for the cosmetic benefit. And even when we're treating for cosmetic benefit, it's pretty interesting that a lot of symptoms get better, and a lot of people after you treat for cosmetic benefits say, I didn't realize how bad the symptoms were. What page we on over there? One more. So, yep. And the hallmark of treatment, the major standby, and what we've done for years is compression therapy. External compression therapy really acts as a new valve for the patient. It graduated pressure, measured compression. A lot of these TED hose that we give the patients after surgery really aren't graduating compression, so they don't act as to return the blood to the heart, kind of mimicking standing in a lake or in water. We have a whole bunch of different components for the patients, all the way, even the most severe deep venous reflux is treated with external compression as the first modality. Lymphatic decompressive therapy is something that's really been more prevalent in the last 15 or 20 years and has been a real adjunct to healing the ulcers. People with arthritis, they can be cosmetically unappealing. They're hot in the summer months. They may create a tourniquet effect if not done properly and actually worsen the symptoms. They can be poorly tolerated in the neuropathic patient, and they're contraindicated in patients with arterial insufficiency and can actually lead to some pretty bad complications if the patients aren't well selected. So this is just the algorithm to treat varicose veins. We put all the patients through a 2 to 3 month trial of conservative therapy prior to any intervention, unless they have ulcerations. And then we kind of go on through a more aggressive workup with most of the workup is done with ultrasonography and duplex scanning and treat the problems. I'll get into those a little more, so I'll go through that picture. The key is they can be confusing. You have to start from the largest vessels and treat the smallest vessels of reflux. So it's really important to create a complete map of the patient's venous reflux before we treat. And so we go top to bottom, largest to smallest. And so treatment of varicose veins for these patients is a process. It's usually not a one treatment situation. It's a multimodality. Surgical therapy for varicose veins, although we've gotten away from stripping of the greater saphenous vein, the outcomes and results of stripping of the greater saphenous vein is still considered the gold standard to which we compare all of our new modalities. That was a fairly brutal procedure that we used to pass a stripper up the vein, tie a ball to the end of it, tie the vein, and just pull them. Got rid of the vein, but there was complications, hematomas, paresthesias. Up to 40% of people you'd injure the nerve as you pulled the vein out. There were a few wound complications. And then there was neovascularization of the sacrofermal junction, up to 60%. That should be between 3 and 9 years. That's a 40-year longitudinal study. And 30% of the patients required reintervention. Putting the incisions out of the diseased skin, you didn't have the wound healing complications. And there were very good healing rates in that population. And then nowadays we do microphlebectomy. That's again gone through an evolution of making large 1/2 to 3/4 incisions along the secondary varicose veins and just tying them off ligation. We found that we could use an avulsion technique and actually just pull segments of veins out, and people wouldn't bleed to death when you break the veins off. And those incisions have slowly gotten smaller and smaller to the point where now we can get some of the biggest veins out of the leg through 2 and 3 millimeter incisions that barely leave a scar on the leg. The complications of microphlebectomy is bruising, phlebitis, scarring, and retained varicosities. That's a picture of some superficial thrombophlebitis. It's amazing how many patients we'll see with multiple ER visits for IV antibiotic therapy for the treatment of the erythema and warmth that goes along with superficial thrombophlebitis. If you treat an infection for 3 or 4 months and it doesn't get better, it's probably not an infection. This is just measuring for the deep system, some valve replacement stuff that they've been looking at over the years. Surgical repair, percutaneous valve replacement really have had some poor techniques over time for the deep veins. Please up for 1 second. Thermal ablation of the greater saphenous vein. This is where we are today for the treatment of the saphenous vein after stripping. There's a couple of different techniques for thermal ablation. Radio frequency and laser therapy have been the hallmarks. And I think that radio frequency ablation has really taken precedence over laser ablation in the modern day. The nice thing about it is it can be done in the office under no anesthetic or mild sedation, local anesthesia, finesse anesthesia, and I'll get a picture of that coming up next. It's a 30 to 60-minute procedure. There's minimal postoperative pain. Most patients can return to work in 24 hours. And by doing it in the office, insurance companies have been a little more favorable for these procedures than OR-based procedures. This is a picture before and after thermal ablation therapy of the saphenous vein. You can follow that with lobectomy, pulling those veins out, the secondary ropey branches. We can use sclerotherapy for those vessels. Some people do it concomitantly, some people do it in a delayed fashion. About 60 to 80% of people, if you just treat the saphenous vein and don't treat the secondary branches, they have symptomatic improvement. And you don't need to do more symptomatically, but you don't get the cosmetic benefit. And this was the plastic surgeons for years and years have been instilling subcutaneous local anesthetic for in-office liposuction, and really those techniques were stolen to do the in-office vein ablation. This method anesthetic is really we inject dilute anesthetic around the vein in order to. It has multiple purposes. One is it numbs the vein so people don't feel the thermal ablation. It creates a heat sink to draw the heat away so other structures aren't injured, and it relatively exsanguinates the vessel by tamponading it in the sheath, and that causes apposition of the vessel wall to the thermal heat source. Go to there. 2 slides. One with the thermal ablation. Yeah. So that's the picture of the radio frequency catheter and the laser catheter. This is a little bit of an outdated slide, but it compares the pain and symptom relief after the symptom relief after closure procedure versus stripping and the number of revascularizations afterwards. And when these procedures first came out, we believed that there wouldn't be needle revascularization at the junction because we left some vessels open and the body still saw a vein in that sheath, so it didn't try to grow any veins. It's now many years later and we're finding revascularization above the junction, so it was a good theory. It takes longer though. And then this evolved trial from 2005 really showed a significant improvement in rate of return to work after endovenous ablation versus surgery. I have a couple of videos. I'm not sure they're going to run though. Won't run. Yeah, that's okay. I just had a couple of graphics from the company on how the endovenous ablation works. The catheter, the radiofrequency laser basically boils the water component of the blood, turns it to steam. The steam causes endothelial damage to the vein. It's associated with more pain, more microperforation of the vessel, causing bruising sensation. So I don't know that patients really got back to the next day activity with laser therapy. Radiofrequency, the early radiofrequency had a higher failure rate than the laser. So we like the laser because of the failure rate. They redesigned the radiofrequency device and we don't see we see very similar rates of recurrence, much less pain, truly back to work the next day for people. So we've gone mostly to the radiofrequency. For the post-closure instructions for people, they wear a compressive wrap for 24 to 48 hours. Then they go into a class 2 gradient compression stocking for 1 to 2 weeks, depending on who's doing it. And then we encourage them to wear those out for a month after the procedure. and all they usually need for pain is a non-steroidal anti-inflammatory medication. I'm going to jump ahead a little bit for time. You can go to slide 51. Got one right there. This is the worst complication of the endoluminal therapy. It's called endoluminal heat-induced thrombosis. There's not a high rate of DVT, but we see these clots migrate through the sacral-femoral junction, and we'd be concerned about DVT in these patients. And so anybody with this E-hit level 3 or higher, we put on anticoagulation for a week and re-image them. I've been doing these procedures since 2005, and we've only had 2 true DVTs in that period of time. That required long-term therapy. Can you skip one more slide there? And then the hallmark of over the years has been sclerotherapy for medium-sized vessels, large-sized vessels. There's different agents that we can use. Hypertonic saline, polydocanol is probably the best one on the market right now, as it's least painful and causes less staining. It was hard to get in the United States for a while, but it's available again. Sotradecol is another commonly used agent. I've not seen many people using the glycerin or the Moriwate, uses Moriwate for hemorrhoids. And there's some pictures before and after sclerotherapy. And then foam sclerotherapy. This one is one that has been kind of iffy over time. We mix the detergent sclerosants with air in a 4-to-1 mixture, and it creates almost a shaving cream consistency of microbubbles. And by putting that in the vein, it exsanguinates the vein. It stays in the vein longer, creating contact with the wall to do endothelial damage. We can get a lot more bang for our buck out of the volume of sclerosant when we do that. Pre-foam. The FDA has never really approved foam. We were allowed to use it in Medicare patients, and they were not allowed to use it in Medicare patients. And now there's a FDA-approved product out on the market. So that's what we've been using. Can you skip one more ahead? There are some scary issues with foam sclerotherapy. People, if they have a history of migraines, you'll see sometimes transient neurologic symptoms in different people. And they are absolutely contraindicated from having foam sclerosant used. We've seen it twice. It's probably associated with a patent form in the valley. And then the only other thing I want to tell you about is toward the end that conclude is FDA had released within the past year a glue to be used within the vein to glue the vein shut. It looks like it's pretty promising, no phlebitis. There's no good long-term data on it. It's basically super glue delivered through the delivery system, much like the closure techniques. Only it's one injection, it's one entry site, so you don't have to use any anesthetic beyond the entry site. And so that's something to watch in the future. And with that, I will conclude.